Well, thank you very, very much, Martin. It's certainly an honor and a privilege for me to be invited to address the Academy here today. I thank you for your kind invitation, and particularly to generate more discussion amongst a forum of critical thinkers and healthcare leaders. We need this sort of discussion in our society. My position is very clear, and the question that was posed to us was very clear as well. It's interesting that we segued over into a discussion around the legalization of marijuana, which of course was not what was presented to us, but is obviously very current and topical. But my position is clear. Widespread decriminalization of illicit substances in order to address problems in the administration of justice, which are certainly there's no disagreement with that, will increase harms to individuals, to families, and society from a health perspective. We will do more harm than good from a health perspective. These harms are not insignificant and not without their own associated costs and challenges. Further, we would be removing from our armamentarium a very useful tool that we really haven't fully explored or utilized. So I have about 8 points to cover here. Point 1, let us explore the nature of substance use harms. Now, Michelle has noted that the harms generated by illicit substances, specifically alcohol and tobacco, exceed those generated by illicit substances, such as marijuana, cocaine, designer stimulants, and heroin. It's not that alcohol and tobacco are necessarily intrinsically more dangerous, but rather widespread availability leads to a heavier burden from abuse. The greater the consumption, the greater the potential harms. Indeed, due to the number of those with substance abuse disorders, alcohol-related harms are greater amongst those individuals than amongst the cohort of people who are truly addicted, or those experiencing criminal consequences. So, large-scale abuse alone equates to larger levels of harm. Prescription opioids offer another example of the negative impact of the widespread availability of illicit substances. Prescription opioids have overtaken heroin in total opioid overdose-related deaths in North America, and indeed have overtaken motor vehicle mortality in both BC and Ontario. This is a public health crisis, in spite of the fact that, number one, prescription drugs are a higher quality, more consistent product than heroin. Number two, there is a monitored and regulated environment that surrounds prescription opioids. Number three, the level of education possessed by physicians is significantly higher than that of most traffickers. And number four, physicians express concern about the well-being of their patients and presumably practice accordingly. Clearly, not all prescription opioids are taken as prescribed. There's a lot of adulteration that goes on. Diversion and abuse are enabled simply by widespread availability. So again, in brief, increased use equates with increased harms. This is not to say that all people who use a substance experience or will experience harm. That would be fear-mongering. It's not true. And that is something that we need to step back from in some of our discussion. Rather, it is to acknowledge, however, that the risk of harm increases with exposure. Let's go on to point 2. The nature of the harms vary with the substance. Typically, these are parsed out based upon acute or short-term harms, and those harms that accumulate over time as long-term harms. Both of these must be considered and require focused, nuanced strategies to deal with them from a treatment or public health perspective. This is why the National Alcohol Low-Risk Drinking Guidelines do not encourage the uptake of alcohol for health reasons. There's no evidence for that. Do not guarantee the absence of risk. There's no evidence for that either. And have recommended limits for both daily and weekly consumption to parse out those acute and long-term harms. Public policy is a blunt instrument when trying to address and mitigate different harms that may arise in different contexts. A sweeping approach is too blunt, too broad. To develop appropriate and effective responses, we must first recognize the nature of these substance-related harms. This is the third point. Michelle commented on the profound ignorance observed amongst youth with regards to marijuana, a fairly ubiquitous drug that clearly needs public education at probably the same level we provide for alcohol and tobacco. Acute harms are more readily identified, but long-term impact may take decades of use and cumulative harm before they can be adequately addressed. Tobacco is an excellent example of the delay in identification and adequate societal response to mitigate the morbidity and mortality attached to a natural product. The comparison to marijuana is important here, as we are still nascent in our appreciation of the cumulative impact on users. Significant increased use has occurred over the last 50 years, but it is a product that has changed substantially over that period of time, from less than 5% THC to over 15%, with an associated decrease in CBDs. This drug is shifting. It's not the drug that some of you probably experimented with decades ago. Daily use has also increased, from occasional users to those that now regularly consume 1 to 2 grams per day. How many joints are in a gram? Typically about 4. So if we're thinking about 10 grams, 40 joints. 30 grams, 120. Do the math. What's also important here is that when people are consuming 4 to 8 joints a day, that there is a perpetual state of mood and mind alteration. This has an impact. The impact on pulmonary function, motivation, and cognitive performance are clear in some instances, but still subjects of debate in others, due to our inability to accurately assess the cumulative dose effect over time. This is why we're seeing more evidence now with regards to the onset of dementia in people that are heavier users. We can be assured, however, regardless of how you want to debate the evidence that we now have, that no mood and mind altering substance is going to be entirely benign. Fourth point, the decriminalization of all illicit substances will increase access to stimulants such as cocaine, crack cocaine, crystal meth, and a range of designer stimulants. The latter is a Pandora's box of substances yet to be created and marketed. Will decriminalization apply to some substances but not others? Who chooses, and based on what evidence? Stimulants are particularly problematic, not only because of the harms associated by acute intoxication, but also because of unpredictable individual response, the greater dopamine surge and propensity for addiction, as well as the cumulative impact on the brain of toxic ingredients. These ingredients are effectively poisons. Michelle has noted, we work hard at removing toxins from our environment, but seem to have a perverse, nonchalant attitude to those used in substance abuse. Are we to regulate the use of the ingredients but ignore the active drug? Is this a rational approach? And it's interesting that those on the contrary side of the panel avoid a lot of this discussion to focus purely on the legalization of marijuana. The issues are broader. Fifth point, there is an assumption that decriminalization will be paired by an increased investment in health sector interventions. Maybe in an ideal world, but this would be good if it were true. Our current responses to problematic substance use is poorly connected and coordinated in spite of the best efforts of the Canadian Centre on Substance Abuse. We do not have a seamless continuum of care. Harm reduction strategies typically meet population health and infectious disease ends, but are frequently a lost opportunity for outreach and engagement of users by addiction counselors. There's a schism there. The implicit message here is that it is okay to use an overdose as long as the activity is ghettoized and removed from the mainstream. The availability of detox beds is inadequate in most jurisdictions. The transition to treatment is often delayed, resulting in a gap that promotes relapse rather than progress. Our slavish fixation on 28 days of rehab is not evidence-based or patient-centered, but rather an historical anomaly based upon funding made available by health insurers in the United States. We can do better. Addiction care requires substantial investment to have programs that are better informed, that are evidence-informed. And if they were, the continuum of care would address addiction as a chronic disease, a drug-induced acquired brain injury, requiring long-term rehab, environmental support, monitoring, and mentoring. The evidence from North American physician health programs demonstrates that a structured, long-term, in their case 5-year, approach to treatment can result in a 75% and 75% people achieving remission with no relapse, and 85% if one includes one incident of relapse. Those are good outcomes, better than we have for diabetes, hypertension, and a lot of other interventions. One can argue that a physician cohort is not normal, with all due respects to the audience, or representative. But just as they are subject to a loss of license and significant professional and personal penalty if they do not comply, so also these individuals have a certain sense of entitlement and the scientific knowledge to know how to game the monitoring system. They can be challenging clients as well. The main point, however, is that treatment results can be better than they are. We need to invest in evidence-based approaches to care. Addiction services have yet to become a full partner within mainstream healthcare, with any and every point of entry to the system leading to appropriate service, which would happen if we had a better integrated model of care. Instead of treating the end result of use, we need to treat root causes. This will not be achieved through the rapid escalation in demand precipitated by widespread decriminalization. In all likelihood, our system, such as it is, would collapse. Much work needs to be done, and I welcome this sort of discussion as a vehicle to generate reflection, change, and improvement in care. Let's explore an entirely different approach. We need a better intersectoral integration of health and justice, with strategies and policies that match intervention with behavior. And in some regards, I'm in agreement with the other panel members. This could involve diverting the acutely intoxicated to detox or shelters with healthcare personnel and appropriate protocols, and linking those individuals to the healthcare needed to address the core issue. Incarceration of the intoxicated may be neither necessary nor helpful, and indeed may result in avoidable deaths in retention. But sometimes this is required for public safety. When societal harms increase because of substance use, criminal censure, properly applied, can be therapeutic. Drug courts, with criminal leverage in the background, have been shown to be a very effective intervention in diverting people from jails, decreasing incarceration costs, and improving health outcomes through mandated treatment. We can follow along this continuum of legal intervention. The most severely addicted have typically lost all insight and control over their substance use and are extremely unstable in the community. We see these individuals. They often suffer from concurrent mental illness, physical health problems, homelessness, and inadequate income support. In spite of the significant self-harm, however, we do not often certify these people to psychiatric facilities when they are in need of treatment. The healthcare system fails them. Many of them challenge our conventional approaches to care. A period of institutionalization, stabilization, and treatment can sometimes only be achieved currently by incarceration, and lives are saved that way. I have people that survive for prolonged, yet another chance at treatment because of a period of incarceration. Is this ideal? No, but we have yet to develop the systems of care that are required to meet the challenge. Why would we give up on intersectoral interventions before we have fully explored the potential? We should be expanding integrated justice and health systems, but to be effective, there must still be a threat of criminal penalty and some consequences as a lever. We need to form a better therapeutic alliance with the justice system, not dismiss its utility out of hand and prematurely. Finally, or point 7, although legalization is not the focus of this discussion, decriminalization is a step towards legalization, as the panel has quickly demonstrated. The costs incurred by increased use through decriminalization, the lack of regulation, the envy of increased cartel profits being denied governments, and the marginalization of chronic substance users, like heavy gamblers or drinkers, will increase the pressure to legalize. This will only exacerbate the harms generated by decriminalization, as I've outlined. And in spite of the eloquence, intelligence, and confidence of the opposition on this panel, I have absolutely no faith that a government that built dysfunctional public policy on the oxymoron of medical marijuana will somehow be capable of designing safe, effective, nuanced policy on illicit drug decriminalization or legalization. I don't think they're capable of it. My eighth and final point, and perhaps the most important one here, is let's not forget that the ones targeted and impacted most profoundly by decriminalization will be our youth, whether we try and avoid that or not. Youth are particularly susceptible to both acute and chronic harms because of their vulnerable stage in neuropsychological growth and development. Just as with tobacco, so also with other substances, will they be the growth market for dealers? Is this the foundation upon which we want to build our future society? Why would we place them at greater risk, abandoning them to implicitly accepted substance use, rather than making a more concerted effort to end their prolonged childhood and bring their considerable talents and energy into constructive, engaged social endeavors? We can do much better as a society than the mere decriminalization of a vexatious problem. We can develop better systems and better public policy, grounded in health and well-being, rather than washing our hands of the most vulnerable and or most marginalized. I submit to you, all of you being professionals in the field of health sciences, that the notion of decriminalizing all drugs would have profound impacts on our healthcare system, on our society, and on our country as a whole. Thank you.